Hi, welcome back everybody. I hope you can hear me. It's great to see you all. Hope you've been enjoying this day so far and have had a chance to visit our sponsors in the exhibit hall and fill out a scavenger hunt form. The deadline for that is 3 o'clock, and to get those in, and so you can win the grand prize of just generously sponsored by OSA for an e-gift card for $100. Also, please visit the posters on the main conference website on the e-posters tab. I'm just waiting for our keynote speaker to join, and we hope to see him soon. Anyway, it's a privilege to have our keynote scientific speaker for this afternoon. We're honored to have him join us, Dr. Joseph Sinecki, who's going to give our keynote scientific presentation today. Dr. Sinecki is a professor and physician at the University of Washington in the Department of Rehab Medicine and is the Associate Dean for Veterans Affairs Research Center of Excellence. Dr. Sinecki's primary clinical and research interests are in amputee rehabilitation, optimizing perioperative decision making to enhance patient outcomes, and electrodiagnosis. We're so excited to hear about his work on enhancing amputation level decision making. Thank you, Joe.
Well, it's a pleasure to have an opportunity to speak with you, and I really appreciate Sandra's invitation to the meeting. It's great to have an opportunity to present to fellow Canadians. I completed my rehabilitation training in physical and occupational therapy at UBC and my MD degree at UBC as well. So it's great to share my experiences with you. So with that, I'll call up my slides. And hopefully you will see them. So are you all seeing my slides?
Hi there. Confirm that we are seeing your PowerPoint presentation. You'll need to go on full screen.
Okay, great.
There we are. Thank you.
Well, why don't we just go ahead and launch in. The title of my presentation today is Enhancing Amputation Level Decision Making and Achieving Outcomes That Matter Most to Patients. I'm sure many of you are thinking, well, you know, this is really simple. I mean, we just have to keep the amputations as distal as possible, and that will naturally lead to better outcomes. I'd like to suggest, however, that what we need to do is to adopt a more sort of personalized approach in our decision making. Not only do we need to adopt a more personalized approach, but we need to adopt an approach that uses some clinical tools to help us engage with our patients to make the best decisions possible. So with that, we'd go ahead and get started. I have no conflicts of interest to disclose. I'd like to acknowledge the research funding I've received from the Veterans Administration for much of the research that we've been doing. And of course, acknowledge the many scientists that have been working on this project with a whole diversity of backgrounds and experience, and each component plays such a critical role in the quality of research that we do. So in terms of an outline of my presentation, the first thing I'd like to do is just touch base briefly on what the complexity of amputation level decision making in peripheral artery disease and diabetes, some of the limitations in current amputation level decision making, how we can possibly improve amputation decision making, and then walk through some of the development of a clinical decision support tool, and then to demonstrate our clinical decision support tool. So I'm sure many of you are wondering, well, how is it that a PM&R physician has a research program that's enhancing amputation level decision making? Well, at our medical center here at the Veterans Administration Medical Center, where I've done the predominance of my clinical work, we have an amputation care team that I'm sure is similar to many of what you have as well in your institutions. So we have podiatric surgeons, vascular surgeons, interventional radiologists and PM&R physicians, PTs and OTs. And we kind of put our heads together, evaluate a patient, and then sort of formulate a recommendation and an overall kind of treatment strategy. So my role in this team would be to evaluate a patient and participate in the way that my evaluation would contribute to helping the team and the patient understand what their potential outcomes might be, and in particular, their mobility outcomes might be. So this is an example of a consult that I might receive, 72-year-old veteran with infected foot ulcer. You can see the spectrum of comorbidities, and there's consideration for either doing a transmetatarsal or a transtibial amputation. And of course, determining what somebody's outcome will be is a very complex task, and there are multiple factors that can contribute to what their potential outcome might be. Everything from their premorbid mobility status, their mental health, psychosocial factors, comorbidities, and demographic factors, as well as the nuances of the physical examination that you perform at the time at the bedside. So amputation level decision making is complex, and one of the limitations that I experienced in my role on this team is that my recommendations were based solely upon my clinical expertise and experience, that there really was no science behind any of my recommendations. One of the questions that I think we all have to ask ourselves when we launch into a research program is this really an important issue, and is it something that needs to be changed? So do we really need to improve amputation level decision making, or are the clinical experience of the team members adequate to do the best decision making? Well, I'd like to present some of the data out there that shows that there's a great degree of variability in decision-making currently. And variability is something that healthcare systems don't like to see, especially if it is variability that cannot be adequately explained. So let me show you, this is the TT to TF ratio, comparing the Veterans Administration ratio with the Medicare population. Very similar populations. There's no fundamental reason why there should be huge disparities or discrepancies in amputation level selection. And what you see in VA is that our transtibial ratio, because it's greater than 1, is actually showing a predominance of transtibial amputation. While in the Medicare population, there's a predominance of transfemoral amputation. Similarly, in the English National Health System, different healthcare regions have differing outcomes in terms of the relative preponderance of transtibial to transfemoral amputation. In this slide, I'd like to incorporate the transmetatarsal amputation as well, and to indicate the relative prevalence of transmetatarsal, transtibial, and transfemoral amputations. So the orange bar is transtibial, the blue bar is transmetatarsal, and the gray bar is transfemoral. And what we see in the southern region of the United States is that there are about 14% transmetatarsal amputations and 40% transfemoral amputations. And in the West region, there is almost an equivalent number of transmetatarsal and transfemoral amputations. So once again, these are huge variabilities that can't be explained by some fundamental difference in the populations in the Western region versus the Southern region. So in addition to this, other research has shown that there are gender differences in amputation level selection and racial ethnic differences in amputation level selection. So here is a rhetorical question. If we require an amputation, should the surgical level be determined by where you live, who your health insurer is, or what your racial, ethnic, or gender characteristics are? And I'm sure you'll agree that the answer is a profound no. Those should not influence the decision. An additional factor that is important as we kind of conceptualize the next steps or how we might improve things is to think about the patient-centeredness of amputation. The Institute of Medicine here in the United States has 6 pillars of healthcare quality, and one of the 6 pillars is the provision of patient-centered healthcare. And I'm sure you'll all agree that this is a critical factor. And when you provide patient-centered healthcare, you ensure that patient values guide all clinical decisions. A newer acronym is P4 medicine, which is healthcare that is personalized, preventive, predictive, and participatory. So this is the idealized example of it. Personalized healthcare, you're making healthcare decisions based upon individual priorities. You can predict what their outcomes will be and how they differ between people, and that you have a participatory discussion between the healthcare provider and the patient. So what are the patient values? Well, this is where we need to kind of understand what the patient's informational needs are, and not only what their needs are, but how we can best present the information to them in a way that is understandable and helps them integrate their values and priorities into the discussion with the healthcare provider. And we also need to be able to provide to the surgeon personalized information. So this is not average information or population information, but how Mr. Jones might differ from Mrs. Smith in terms of their healthcare status and how that can influence their potential outcomes. And there's very little evidence out there to guide personalized healthcare decisions. And then from a participatory perspective, as I mentioned, we have to bring the patient and surgeon together to have a shared decision-making discussion. So our approach that we've been working on for about the last decade or so, it's remarkable looking back, is to provide and develop and provide a patient decision aid to better inform patients and have them be able to integrate their personal values and priorities, and also to develop a clinical decision support tool. And they both come together better informed as they make a decision about what amputation level might be best. So because of time limitations in this presentation, I'm only going to address the decision support tool side of the equation, and perhaps save the patient decision aid for a future time. A clinical decision support tool, I don't know how many of you are familiar with them, but they are tools that are developed to provide patient-specific information. They're intelligently delivered, filtered, and delivered at the point of care. So they need to be available to the surgeon at the time a critical decision needs to be made. And in this case, ideally, it would be available in the electronic health record. And of course, the overall goal is to enhance health and healthcare. So to get the evidence to feed into a decision support tool, what you need are prediction models. So the prediction models will look at specific patient information at one point in time, at the time that decision needs to be made, and then provide outcome evidence into the future. And as my colleague Dan Norvell says, the prediction models are the engine for decision support. So in terms of systematic reviews of prediction models in dysvascular amputation, it's handy actually that Ryan Priest from the UK just has a paper in press in the European Journal of Vascular and Endovascular Surgery where he did a systematic review of prediction models. There are 12 published papers that he included in his systematic review. 7 included mortality as an outcome, 1 morbidity, 2 ambulation, and 1 reamputation. The majority of these studies were done by surgical groups, and the focus was predominantly on that 30-day window where complications, anything that happens within 30 days of a surgical procedure is viewed as a complication of that procedure. So that has important ramifications, but perhaps we need a longer timeline so that we can actually predict what will happen further into the future. Ryan actually included 3 of our prediction models in this systematic review. So what are our prediction models that we incorporate into our decision support tool? We incorporate a mortality prediction model, that's 1-year mortality, a 1-year outcome of failure of healing and need for additional amputation, and a 1-year outcome of mobility. And these were published in the Journal of Vascular Surgery, and 2 of them were in the British Journal of Surgery. So one thing that you may be wondering is, why did we focus on mortality, especially 1-year mortality, as an important component of prediction modeling and the development of the decision support tool? It's interesting in terms of the culture of cancer care. One of the key features is that when patients present and receive the diagnosis of cancer, oftentimes one of the first questions is, gee, doc, how long do I have to live? Because that's an integral component to their treatment planning and basically their life planning. So it's interesting to see that this is not typically part of the conversation. And yet when we look at the 5-year survival of patients who undergo a disc vascular amputation, it is actually worse than many cancer diagnoses. So we felt it was critical to incorporate a mortality prediction model, and not just a 30-day operative mortality, but a 1-year mortality, so that patients can kind of integrate this into their overall decisions. So in terms of our prediction model development, I'm not going to spend a ton of time. I'm going to gloss over how we did this, but the mortality prediction model and the re-amputation prediction model were both VA large data set. They had over 7,000 patients in the cohort. The inclusion criteria were that they needed to have that this be their incident amputation, so their very first amputation. We felt that it was important to kind of limit that, because if we make the best decisions possible at the time of the very first amputation, the odds are we're going to improve the care of the patient throughout the remaining lifespan. We excluded some patients because of their severe neurologic deficit or underlying factors that might contribute to a marked increased risk in mortality. We started off with 33 candidate predictors based upon the literature and expert opinion. And our goal was to develop a model, not the best model possible, but the best model incorporating the utility of the model. Because if you have, for example, a prediction model that requires 100 inputs to give you the absolute best quality model, nobody's going to use it. So we used a 95% step-down logistic regression, and at least with the mortality model, we use external geographic validation. So there were 7,168 patients in the cohort. Almost 2,000 died within 1 year. And these are the 10 predictors and the coefficients, which basically allow you to kind of ascertain the relative contribution to the overall prediction. The C statistic is 0.77, or the AUC, which is actually a good, reflects a good model, and the Hosmer-Lemeshoff goodness of fit at 0.52 also suggests that this is a pretty good model. Its modeling characteristics and its predictive value are pretty good. I'd like to show you one additional feature. If you look at the average mortality of the whole population, this cohort of 7,000 people, 26% on average would die within that first year. But in the lowest decile of risk, the risk is actually less than 5%. And then the highest decile of risk, it is actually 62%. And I think this just sort of reinforces the notion that communicating average risk to a patient, if you happen to be that average patient, that's great. But if you happen to be outside of that average, you're actually providing some misinformation that will perhaps inappropriately guide a patient to the wrong, or the surgeon to the wrong kind of decision. We also developed a mobility prediction model, which used a totally different methodology because mobility outcome measures are not incorporated into the average medical corporate data warehouse. So we actually had to do this prospectively. And we recruited 200 patients, and 157 completed the overall 1-year follow-up period. And this reflects the basic, the predictors that contribute to basic mobility, and then the predictors that are linked to the advanced mobility. And this is based upon the use of the LCI-5 as our outcome measure. And the LCI-5 can be looked at as a total score or as a basic and or advanced mobility score. So what about the development of a decision support tool? So now we've got the prediction models in our hip pocket. We can predict what's going to happen in the future based upon pre-amputation factors. But then we need to develop this tool and to evaluate the tool and modify the tool so that it enhances its potential for implementation. So our development process included an expert panel to begin with. Once we had developed this online tool, we got expert panel input to say, you could modify this, its readability is poor, the way the information presented could be enhanced. We then recruited 10 vascular, podiatric, and PM&R physicians from a nationwide sample to use a mixed methods evaluation of qualitative input into the development of the decision support tool. And then we performed this usability test with the PSSUQ, then went back to the expert panel, and then developed a more final online decision support tool. So with that, I'd like to show you the decision support tool. And here it is. Wow, surprise. What our goal is to have a single portal where both the patient decision aid and the decision support tool are available to either patients or providers. And I'm going to click on the, this is just showing you the complete page here. I'm going to click on the decision support tool. And as with many decision support tools, we felt it was important to have a disclaimer, basically that this tool is meant to augment other laboratory and other investigations, but it should not be used exclusively to make a determination. And this is the home page of the decision support tool, and a user could click on provider-patient benefits, what patients are eligible for use of the decision support tool, and they can actually look at the papers. There are links included here to look at the papers that contributed to the development of the decision support tool. And with that, I'll go ahead and say, well, let's go ahead and look at this risk calculator. Once again, to ensure that the decision support tool is used appropriately, we wanted to make sure that the key inclusion/exclusion criteria of a potential patient and that is going to be incorporated into the decision support tool is appropriate. So yes, they were ambulatory at the time of their amputation, and no, they didn't carry one of the diagnoses that I previously discussed. So this is the data input part of the decision support tool, and it includes demographics, comorbidities, laboratory values, and health factors. And I'm not going to work through this, but you can work through it page by page, and it's basically radio buttons with a few portions of actual keying in information. What I'm going to do is to take you through an example patient. This is a 72-year-old patient with an infected first MTP joint, and there's consideration for amputation at the TM or TT amputation level. These are the patient's characteristics that will be input into the decision support tool. So we've pre-populated the decision support tool here just from an expediency perspective. So when we use it during our presentations, we can actually have it filled in rather than walk through filling it in. So this is the first page, demographics, and the comorbidities. And we have informational buttons that if you hover over, you can see what revascularization means for the purposes of this risk calculator, and whether or not they were on anticoagulants and what types of anticoagulants were incorporated into the prediction model. And now we're at health factors and the functional status of the patient. We have whether or not they're independent, partially dependent, or totally dependent, and how they rate their general health. So once we submit this, what we end up with is a graphic display of the patient's risks for the key outcomes. And as I mentioned, we felt that mortality was important. And for the purposes of that first patient, their risk is actually fairly low for mortality, and amputation level doesn't profoundly affect their risk of mortality. And let's look at their reamputation risk and their mobility outcome. So in this situation, the risk of reamputation between transmetatarsal and transtibial is about the same. Transfemoral is markedly reduced risk for need for reamputation. And our definition of reamputation was any additional surgery on the residual limb, whether it be soft tissue revision, bony revision, or revision to a higher level. The ambulatory mobility, once again, we used whether or not they were at least be able to achieve basic mobility as defined by the LCI-5. And you can see the differences in the effect of amputation level. Now, if I go back and say I'm going to modify the input, perhaps it's a different patient, I'm going to make this patient more sick, congestive heart failure, on dialysis, has diabetes, has revascularization, which many patients do. They have actually more evidence of infection. Their white count is elevated, renal function is impaired, and I will make them partially dependent rather than independent, and their self-rated health is being poor, and submit that. And what you see here is that they're 48% risk of mortality within the 1 year, or 55 or 59, depending upon their amputation level. And their reamputation risk at the transmetatarsal level is extremely high. And at the transtibial level, it's moderate, and transfemoral level is still
Joe,
low.
are you near the end of your last slide? Sorry to interrupt. We're just wondering if you want to have a couple of minutes for Q&A at the end.
Yes, I will. This was sort of the end of the prediction tool, and I'll just close with one slide here. So what we've been talking about here is the providing of evidence and numbers that reflect probable outcomes of patients. And I think one of the risks here is the issue of maintaining hope. And hope has been associated with positive health outcomes, and the absence of hope with adverse health outcomes. And I think it's really important that when we communicate with patients, that we first of all demonstrate caring and compassion, and that we can help them reimagine a future and its possibilities because we understand their values and priorities. So I think that Information is good, but how we present the information in the final analysis is probably a critical factor in how we shape their ability to adapt and accommodate to their amputation. So with that, I'll say thank you.
Thank you, Joe, for an excellent talk and just reminding us how important it is to make the best decisions for our people that are facing limb loss. And I just see a couple of very important questions in the Q&A. The first one is, thanks. Any reason you didn't include knee disarticulation patients in the study? Usually decisions between transfemoral and knee disartic is challenging for patients and the medical team. What is your experience with that?
The first part of that was, why didn't we include transfemoral amputation, or
knee disarticulate patients, through knee patients
yes.
in the study?
And that was
I'm afraid we might have lost Joe again. Joe, if you're there, if you can, there you are, you're back. Thank you.
okay.
Yeah, so in the Veterans Healthcare system,
Knee disarticulation amputations are performed really uncommonly, and you need to have a certain end to be able to have a prediction model that is strong enough. So we bundled knee disartics, the few that were there, with our transfemorals.
Thanks for your question, Arazu. Does that answer your question? Good. And we have another question as well from Mike Payne. Love the tool. In your center, how frequently would you would a physiatrist provide input to the pre-surgical period, both acute and more chronic presentations?
That actually is, I wouldn't say it's all the time. I think in emergent situations, the PM&R input is probably secondary. The patient comes in with acute limb ischemia, and a decision is made. There's no revascularization options. They need to have an amputation done promptly. We probably wouldn't be involved in that pre-amputation discussion. But we certainly, as far as patients that are experiencing chronic limb ischemia, chronic pain after trauma, they come to our clinics. And then, of course, when they are inpatients, and we are part of the team and we participate in that pre-amputation evaluation.
Okay, great. Thank you so much, Joe. That was a fantastic talk, and we appreciate you bringing all your expertise to this area, and for being flexible in joining us later as well to adjust to our changing schedule with tech. Anybody knows me, I often have challenges with that. So thank you again, Joe, for all you're doing.
Well, it's a pleasure. Thank you, Janet, for moderating, and once again, thanks for the invitation. It's been a pleasure to talk with you all and follow along in the many presentations that were done. They're exceptional.
Great, and I hope you're around for a few minutes if people want to connect with you to ask any few last questions.
Sure.
Thank you, Joe. So we are going to have another 5-minute break in a minute, and we will rejoin at 3:15. For those of you that are joining later, we did have some changes to our schedule because of tech difficulties, and we will be going to the final stretch of our conference with our panel discussion, our ISPO-sponsored poster session, and then in our closing remarks. So we'll be back at 3:15. The session with Sandra and Crystal regarding the OAAC project that they were doing will be recorded, and we'll make that available to you later. So there'll be details about that. It will be on the website. So thank you, and we will be back in 5 minutes.